the Zoom platform, but then we made it available also as a Facebook Live video. For your information, like if you want to share something about this webinar on social media, please use the hashtag MHESME webinar, and then yes, the usual hashtags, hashtag mental health, hashtag COVID-19. I would like now, and I'm very pleased to introduce our first speaker, who is Dan Chisholm. He's a program manager for mental health at the WHO Regional Office for Europe, based in Copenhagen, Denmark. And he works with the WHO member states and other partners to develop and implement national mental health policies and plans and provide guidance, tools, and advocacy for the promotion of mental health and prevention and development of prevention, treatment, and recovery services. So please, Dan, the floor is yours.
Okay, hope you can hear me. Thanks a lot, Claudia. Good afternoon, everybody. It's pouring with rain here in Copenhagen for the first time in 6 weeks, and all I can say is thank goodness it hasn't been like this for the last few weeks. God help us. Thank you so much for organizing this event, Claudia and colleagues at Mental Health Europe, and for inviting us all to join in. I think it's really timely to be doing this at this moment, because of the stage that we've reached as countries slowly but surely begin to consider the kind of transitional steps or arrangements out of lockdown and begin to really grasp and grapple with the longer term implications and needs in the population as we try and plan for recovery from this crisis, both in terms of the health crisis, the health system crisis, but also, of course, the economic aspects. And most importantly, the recovery of affected individuals, bereaving families, traumatized communities in the worst affected parts of Europe, for example. And in all of this, let's need a special kind of focus on the more vulnerable groups in society. So I will take a few minutes to share some thoughts on a number of the more prominent or concerning risks to mental health, risk factors for mental health in the population, which of course are already very apparent in many cases, but which also in many cases can only be expected to grow in prominence and importance. And so I've got this slide here. I've only got one slide, you'll be pleased to know, which helps to kind of represent some of those risk factors. And I'll go through them, but just to introduce the kind of point that we need to consider this in a staged or phased manner. That of course we've been seeing the acute effects, the short-term effects, but then we need to start already thinking about some of the expected mid-term and longer-term effects and impacts. And for this, of course, we can draw on the experience of earlier pandemics, outbreaks, economic crises. So this is what you see in front of you is a kind of synthesis of what we already know is happening, but also what we know is expected to happen. And therefore, that is a very important way of focusing the mind on what needs to happen to mitigate these effects. The final other sort of general point is that this is not one of my, I didn't produce this. I didn't produce this from a mental health specific point of view. This is a recent publication from WHO Europe looking, as it says, at about broad ways in which the public health response can be strengthened as we go through these phases. So it's coming from a general perspective. And yet, when you look at the general issues, public health measures that need to be considered, you can see mental health all over this slide. So I didn't see the need to adapt it because we already see staring at us. We already know as a community, but all of the mental health effects. Some of them are direct, like we have here, for example, increases in levels of stress and anxiety, which we know will, have increase the likelihood of higher rates of self-harm or suicide, and the risk of longer-term mental illness in the longer term. So that's an example of a very direct mental health effect. But we know, and as we will hear from other speakers, about, for example, the economic effect. So of course, people have lost jobs, they've lost employment, they've lost income in the short term. And what are the implications? We know that that unemployment is a very strong risk factor for mental health. So we know that the longer term unemployment rates mean a significant risk for population mental health. And we probably need to do as much as we can to communicate that, explain that to our different stakeholders, not teaching ourselves, which we already know this stuff, but all the other stakeholders who we come into contact with. So another one which has been very prominent, in the press, of course, is around the rates of domestic violence, particularly against women and children in lockdown situations. And we know, for example, that adverse childhood experiences is one of the most powerful, important predictors of subsequent psychological morbidity and mental health problems, and not just mental health problems, but also other health conditions, including, of course, substance use and related problems. So I'm touching on just on some of these. You can look through the different particular items identified here, how one set of risk factors in the acute phase leads to expected increases in the middle and long term. So this is what I wanted to say about or draw your attention to on the range of kind of risk factors. There are, of course, some others which are not represented here. We didn't have anything particularly on, for example, on age as a risk factor, in both from mental health point of view, but also obviously from a COVID point of view. And also other more cultural issues, for example, religion, religious practice. So, the fact that Christians weren't able to go to church over Easter. We're now in Ramadan. This is extremely important time of the year for Muslims, and not being able to go to pray, can prey on the minds of those people. So we need to be very aware of a very broad range of changes in society, which will and can affect the mental health status of the population. So if we know, that these are some of the potential unexpected impacts socially and economically on mental health, then, what can and should be done to mitigate these. And here, what I always like to say is that for every adverse factor or risk factor, there's a protective factor. So we just need to flip the coin. So when we, for example, think about about loneliness that has been forced on so many people, maybe for the first time for many people living on their own, we need to flip that and think, well, togetherness is the protective factor, which we can't do in physically, but we can do through all kinds of media, like we're communicating here today. And so having strong social networks and supports for people who are lonely. I mean, we hear incredible, wonderful things about how communities are rallying around people living on their own, particularly older people. So another example, obviously would be around, for example, discrimination and stigma, whether it's against health workers or against Chinese or others who are some reason associated with this with COVID-19. And so how to amend that is through effective communication and targeted sort of mental health literacy or awareness programs. And we can go on, whether it's, for example, economic recovery programs for the unemployed and so on. And I think my final kind of point would be that in adversity there is opportunity, and I think that is very true for public mental health, because traditionally and still today it's very neglected as an area. But if there's one thing that has become blatantly clear through this crisis, is that mental health matters, and people get that everyone is experiencing stress and anxiety, and that this is a normal human reaction to uncertainty. And therefore we have a huge opportunity here to use that acceptance and knowledge amongst all households at the moment that mental health is important, and what can we do to protect it and promote it, and also beyond that to perhaps build back better as well, in terms of utilizing some of the innovative technologies like we're using today to increase access to evidence-based care, to use the opportunity to show that long-term institutions are not only bad for human rights protection and for recovery, but they're actually unsafe places to be. It's another reason to advocate strongly for development of community-based services and reduction or closure of some institutions. And so on. So in the area of workplace, which, maybe there's a greater opportunity now for wellness at work schemes that integrate mental health more fully into those programs, just like in schools, socio-emotional learning programs, and so on. So I think I'll leave it there and pass back to you, Claudia. Thanks for your attention, everybody, and look forward to the discussion.
Thank you. So thank you very much, Dan. I think that unless there is a specific question for clarification on what Dan has said, we can pass to the next speaker. But I wanted to thank you, Dan, for raising some very, very important and relevant issues, including the issue of stigma, and which we have seen. There have been some instances in which, for instance, persons with psychosocial disabilities or mental health problems that maybe in some countries were actually allowed, for instance, to be out a bit more, etc., that have been encountered with by the public and also by public officers with not with the needed openness. So there is definitely very much the need, I think, for increasing mental health literacy for everyone. And also thank you for talking about the concept of togetherness. I'll come back by the end of this webinar with a few words on why this is particularly relevant for us at the moment. So I would like now to introduce our second speaker for the day. It's Steve Appleton. He is the European lead for the International Initiative for Mental Health Leadership, and he coordinates their work in the UK while working closely with colleagues in Europe, but also in the USA, Canada, and in Australasia. And as part of this role, he co-facilitates the work of the iCircle Collaborative, which brings together cities from around the world on work related to population mental health improvement and prevention. So please, Steve.
Thank you, Claudia, and good afternoon, everybody. It's a great pleasure to be with you this afternoon. And in these challenging times, it's good to have so many colleagues from across Europe joining us to speak about mental health and the impact of COVID-19. on mental health. And I just want to do two things this afternoon. One is to start off by saying a little bit about the International Initiative for Mental Health Leadership, in case some of you don't know about the organisation, but then to talk a little bit about the impact of COVID-19 on community mental health services, both in terms of their provision, but also how we might respond to some of the challenges that it presents for us. Clara, I don't know if you're able to move on to the next slide for me. That would be pretty helpful. Terrific, thanks. So just a little bit about IIMHL, the International Initiative for Mental Health Leadership. It's an organisation that's been around for 17 years. We have 9 member countries. I won't read them all out, they're there for you on the screen. But we also work with other countries who are not formal members, including those in the Nordic area, as well as some work with colleagues in the Czech Republic, 1 or 2 other countries, including Spain and Germany and Belgium too, a little bit now. But also working closely with a range of different organisations. I've listed some of those in Europe in particular that we work with, including, of course, closely with colleagues here at Mental Health Europe, but also with Dan and others within WHO, UCOMS, and also the City Mental Health Alliance, which some of you will know, as well as a number of other government agencies and NGOs. What we aim to do through our work is to rapidly transfer information and knowledge and expertise through a professional network, spreading innovation, encouraging and disseminating good practice, and supporting leadership development among countries. Our focus is predominantly around mental health, but we also have another organisation as part of our overall network called the International Initiative for Disability Leadership, which involves working with colleagues who are working on issues to do with physical and intellectual disability. We engage with a range of different people, but leaders at all levels and across all professions who influence the conditions for positive mental health, and those who work to deliver the best possible outcomes for people who use mental health and addiction services and their families. And next slide, please. Great, thank you, Claudia. So in thinking about community mental health, I think what we've seen across Europe and in other parts of the world too over the last 20 or 30 years has been a progression towards a greater emphasis on the provision of community mental health services. As you'll see, the WHO European Mental Health Action Plan set out the aims and objectives for improving mental health, and within that it highlighted a commitment to deinstitutionalisation and the greater development of community-based services. I think all countries have moved in that direction, and that progress is a little bit uneven. And if I think about our experience here in England and the UK, I think we made some rapid progress between about 1999 and 2009 with our National Service Framework for various reasons, not least of which austerity from the economic crisis. We may have slipped back a little bit from that. But there are several countries across the region that provide a comprehensive network of community-based services. Some still rely on large mental health hospitals, but I think the different sorts of approaches that are available and being offered are varied. There are a number of really good examples of practice across the European region. Everybody, I'm sure, will be familiar with the work in Trieste, which is really the kind of the seat of community mental health in many respects, but also services such as FACT in the Netherlands, the improving access to psychological therapies and crisis home treatment teams here in England, as well as collaborating networks in Belgium. There are many others that I could have listed, but so apologies if your example isn't there. The next slide, please, Claudia. So I think we're all familiar now, since this all began over the last certainly couple of months, the impact of COVID-19 on the way in which we are delivering health and care services, not just in the acute care sector or the physical healthcare sector, but in mental health too. And that's the case both in hospitals and the community. Particular countries have had their own specific challenges, and we know that in Europe, Italy and Spain were amongst the first and most rapidly affected. Sadly, the United Kingdom, as all of you will be aware, is experiencing significant issues in relation to transmission and death rates. And we may well be through the initial peak, but we're not yet on a prolonged downturn in either transmission or sadly in terms of fatality. That has a really profound effect for the delivery of services and the perceived risk in delivering services to people, not least of which also is the availability of our workforce. And we know that around about 100 people in our National Health Service who are working within that organisation as a whole have already lost their lives. And there is also a perceived risk in terms of receiving services. So people have concern about coming into contact with health and social care professionals, both in hospital and in the community. So some countries across Europe are facing bigger challenges than others. And that's also in relation to issues such as the bereavement and trauma that affects both the public and the workforce as a consequence of effectively a mass death. And also the sorts of concerns and anxieties that arise from fear of transmission of the disease. And some of the other issues that Dan mentioned earlier on in relation to social isolation, loneliness, all those kinds of issues. The use of lockdown measures across various countries in Europe has clearly reduced the ability of community mental health services to practice in the way that they always have done in the past. Now that's meant that there have been some changes in practice, and some of those have happened very rapidly, but it's also led to some reductions in the level of services and also issues relating to the management of certain medications, for example. So long-lasting injectable medication is just one example of that. In some jurisdictions, we know that there have been some emergency amendments made to mental health legislation in relation to compulsory detention treatment in hospital. Here in England and Wales, our Mental Health Act has been amended, although those amendments have not yet been enacted, but they stand ready to be should that be necessary. And social distancing measures, of course, mean that community mental health practice has changed significantly in the past 2 months in the ways in which people can go out and be visited at home or indeed take part in community-based therapeutic groups, for example. Next slide, please, Claudia. So here are some examples of some of the different things that are being done in just 4 countries. I'm very grateful to my colleagues at the Australian National University's Centre for Mental Health Research, who have hosted a series of webinars over the last month, really, all of which have had presentations from different countries looking at the impact of COVID-19 on their mental health services, but also on their healthcare services more broadly. I don't propose to run through all of this now, but you can see that in Denmark and in Italy, here in England, in London and in Spain, a number of different challenges and changes being made to the way in which services are delivered. And I think what stands out is a greater reliance on telehealth and digital technology. So lots of video consultation. I mean, in Denmark in particular, that's gone up by 1,000% in relation to outpatient clinics. Trying to ensure that where there are a majority of community-based services, there are specific measures in place to try and deliver those as effectively as possible. But there are, of course, limitations on the accessibility, and that's what's led to some degree of reduction, I think, certainly here in England, but also in other countries too. Next slide, please, Cardi. So it's not only changes in practice, but also the direct impact on services themselves. And I think what we see is an extending of waiting lists, and in particular, people, as I mentioned earlier on, the concern about accessing services. This is not just the case in terms of acute care, where we know that, for example, in England, attendances at emergency departments have dropped off significantly, and people with longer term conditions being concerned about going to hospital. There's also a kind of storing up of demand, therefore, as a consequence of that. And in terms of mental health, it may be that mental health problems are beginning to appear for individuals that weren't there before, but they're not getting in contact with services perhaps as swiftly or indeed as easily as they might have done in the past. So we have to be aware of that demand waiting down the track to some extent. And also the exacerbation of other problems and critical harms, by which I mean, if we think about people who, for example, are homeless, people who may have addiction problems, but also as a result, and Stephen will talk about this, I'm sure, later, in terms of the potential issues in relation to unemployment, issues around availability of income, welfare benefits, all those other social determinants are directly affected by this, as well as the issues around the lack of social contact and isolation and loneliness that Dan mentioned earlier on. However, not all the impacts are negative. As I mentioned, we're seeing enhanced digital working, and I think in many countries where departments and organisations have been seeking to drive forward with digital working and telehealth, they've experienced barriers over recent years. Well, those barriers have very swiftly come down, and people are finding that there are opportunities within the digital workplace to try and engage with people, to work together effectively. We've overcome quite a lot of organisational barriers, many of which were probably artificial, but we've broken some of those down, I think, quite effectively between different agencies and organisations, and made some positive cultural changes as well. In England, if you'll forgive me, the slightly parochial view, I guess, but a really, I think, interesting approach is the use of a thing called the Local Resilience Forum Framework, which has been really successful in bringing different agencies together, by which I mean healthcare services, social care services, the police, fire services, some other organisations, some indeed in the voluntary sector, to work collectively very closely based on a principle of mutual aid. So really thinking about system working in a very different way, and in the sort of idealistic way that we all tend to think about it theoretically, it is actually coming true. And I think those are legacy lessons for us that we can learn from and that we can use to inform our future response, not only to this pandemic, but other future crises that we might face in coming years. Next slide, please, Claudia. So this is an interesting little picture that I should credit for being shared with me by my colleague Paul Burstow, who many of you will know, a former Care Services Minister in the coalition government, and now the chairman of the Social Care Institute for Excellence in England. And he and a number of colleagues have been doing a lot of thinking about the impact of COVID-19 and what it means in terms of the future. It suggests that there are probably likely to be around 4 waves of activity associated with COVID-19, and that the mental health impact will be particularly high, and that impact will have some degree of lag in terms of when it becomes most visible and is felt most not only by individuals but by services too. So that tells us that we need to be prepared for that, and we need to move from critical response into preparedness for the recovery phase of this process and this crisis. So how we respond in terms of our community-based provision and interventions, as well as Dan mentioned earlier, population-based approaches to mental health and well-being will be critical, I think, in how we address that 4th wave that's in that picture. And that might be an example, for example, where local resilience forum type approaches of mutual aid, of collective working may be helpful. This is not simply an issue to which only providers of mental health services can respond, because we know that the determinants that impact upon mental health are wide-ranging. So it is beholden upon all agencies to work together collectively. Next slide, please, Carrie. So although I try to remain optimistic about this, and this current crisis will pass, we don't know how long it's going to take to pass, but it will. But its effects will be with us for a significant period of time. And indeed, it may be years, not months. And indeed, there may be further waves of this virus to come. So that means we have to change our approach. And what I've set out here are some just bullet points really about some of the things we might want to think about in respect of how we plan for that approach going forward. So telehealth provides a number of opportunities for us to reach people, to engage with people, but it also has some risks. I was reading something recently about the sort of disassociative nature of Zoom calls and MS Team calls. It's not quite the same as being in the same room as somebody. So we have to be careful about how we use those and recognise that some people will find it quite difficult to engage in this method of communication. There needs to be an adaptation in the way in which we work to address need. So rather than falling back on a simple and generalized offer, we have to think about how we tailor some specific interventions to address the impact of COVID-19 on mental health. And I know that, for example, there's been some interesting work done in Edinburgh already in developing some psychological interventions that are specifically tailored to the impact of COVID-19 on people's mental health and well-being. There is some concern about the potential rise in suicide as a result of COVID-19, and clearly we might want to look at the adaptation of suicide prevention and reduction plans. We really need to look after the people who are working in our services. They are exposed to a number of challenges. And as I mentioned earlier on, the impact of mass fatality in particular, the trauma that they may experience. We need to make sure that leaders are well equipped to look after the workforce, and the workforce are well equipped to look after each other and themselves. There is emerging evidence that I'm sure all of you are aware of, that this disease, this virus, is affecting people from Black and minority ethnic communities in particular. So we really need to think about addressing those inequalities, many of them of which are structural and need addressing anyway. This may give us some greater impetus. BAME is one example. There'll be other inequalities that we also want to tackle, particularly in relation to availability of housing and issues in relation to income. Cross-sector collaboration, we talk a lot about how important that is. We find it harder to do. As I mentioned, the Local Resilience Forum approach does give us some clues to how we can do that in terms of a mutual aid approach, but I think we need to think carefully about how we bring different sectors together to create that multi-sector collaboration. And Dan referenced this earlier on, and I'm a very strong advocate, and anybody that knows me will know, of having been involved in population mental health and wellbeing and prevention programs, often under the banner of Thrive. I think this is a really good opportunity to leverage the importance and the impact that population mental health strategies can have in improving the mental health and well-being of populations more broadly, because we must be careful not to over-pathologize normal reactions to these kind of events. It is okay to be concerned and to a degree anxious about the impact of this virus more broadly. So I think we can take a two-pronged approach. Next slide, please, Claudia. I think most importantly, we have to, in a sense, recommit ourselves to community-focused population health and well-being. It'll be harder to do that in terms of social distancing and all the kind of practical issues, but just because it's harder doesn't mean that we shouldn't do it. We must not allow ourselves to take a retrograde step back into old ways of working, but we must try to plan our way through what is now much more uncertain terrain. Our only certainty at the moment is that COVID-19 and its impact is here to stay. I'm suggesting we should take an approach that composes of 3 phases, that we should deal with our initial response. We should then begin to plan to recover with the ultimate aim of enabling people to thrive. But for each of those phases, we have to ask ourselves 3 key questions, it seems to me. How do we globally learn from each other? And in particular here in Europe, how do we as colleagues across our European countries learn from each other, collaborate effectively, and come up with some interesting approaches? How do we adjust and transform those approaches and rapidly mobilize them so that we can really get the best outcomes? Because actually speed of mobilization is going to be important as part of this. And thirdly, how do we evaluate how effective we've been at doing that? And are the new innovations that we might develop as a result of this effective? And if they're not, what modifications do we need to make? So I think that the key challenge is perhaps not about the things that we plan to return to business as usual, but how we build upon this initial response to COVID-19 that facilitate a means by which we can effectively flip the switch to make those services and interventions as flexible as possible around possible new waves of the virus, while we maintain wider population health, mental health and well-being. That's it. I think there's a final slide which just has some contact details on, but thanks very much for listening.
Thank you very much, Steve, for this very comprehensive presentation, and also for you highlighted a lot, and everything very much resonates with us, including the issues of potential increase in the use of coercive measures, especially if national legislation is being amended in this particular time, and also the fact of whether there will be an increase in the demand of access to services, which always makes us think, will there also be a risk of the over-medicalization? So I think that as there are not, cannot see very quickly, and looking at the questions, which we are receiving already quite a few, there are not specific questions for clarification, but we can, of immediate clarification, we can get back to those questions afterwards, after we have heard from our last speaker for the day, Stephen Bevan. Stephen Bevan is head of the HR Research Development at IES, and he has a responsibility for developing innovative new projects and programs with their collaborators. And he has a special interest in workforce health and well-being, having led a number of national and international projects that focused on this topic and on the impact of chronic illness on productivity and social inclusion. So the floor is yours, Stephen.
Thank you very much. So I'll be focusing more on mental health of the employed population and talking to you a bit about some of the work we've been doing, looking at those people who are suddenly having to work from home as a result of the COVID-19 crisis. The Institute for Employment Studies is a charity that does research on all aspects of work, but we have a big focus on the health of the working age population. And we've done work looking at the employment of people with schizophrenia. We do a lot of work in the UK with organisations like Mind. And we're currently running the evaluation of the world's largest randomised controlled trial to look at supported employment for people with depression and anxiety. So we look at policy as well as organisational practice. One of the things that's really clear from the lockdown across the developed world is that lots of workers are now been working at home for several weeks now. So it's represent a very quick and large scale shift in working patterns. In the UK, it's hard to estimate, but we certainly know that over 7 million working parents are now working at home, so trying to work and look after and homeschool their children. We've been carrying out a survey of people's well-being since the beginning of the lockdown, and we've now had over 850 responses to that survey. And so I'm going to give you a few headlines around what we found. I mean, I guess the key thing to remember, of course, is that working at home is still a relatively privileged position. If you take the wider impact, there are lots of people such as key workers, people working in health and social care, who remain exposed, aren't able to have the protection of working at home, and therefore there are big questions about how health inequalities, the social gradient in health, will be exacerbated by this crisis. So in focusing on those people working at home, we fully recognise that we're dealing predominantly with people in primarily professional and administrative and white collar type jobs. But we're interested, of course, in how they've been reacting to the challenge of working at home. In our survey, we found about 30% of people are working at home with children, about just under 20% working with, have elderly relatives. About 40%, 45% of our sample are also managers themselves. And I think one of the things that we're already learning is that we need to think very carefully about how the mental health of managers, trying to manage very atomized teams in very challenging circumstances, coping. And about 40% of people working at home are sharing their workspace with another adult who's working at home. Go to the next slide, please. So there's good news and bad news about how working at home is affecting people's well-being more generally. On the left-hand side, you can see some of the good news stories. When we asked people to provide a free text answer to the best things about working from home, the not having to commute came easily the top. And for those people not able to commute, not needing to commute, they're finding some interesting ways of using that spare time to engage in more discretionary activities. People are enjoying, in general, the flexibility and autonomy. Many people feel positive about how it's affecting their productivity. Many of them feel trusted to get on with things. There's lots of really positive stuff around how people feel committed and able to do good quality work. And apart from obviously having children, relatively fewer distractions, so people are able to concentrate more. Of course, on the other side, there have been some quite difficult negative challenges. We found a really big spike in people reporting musculoskeletal pain. So about 58% of people said they'd had more neck problems, shoulder problems, back problems since they've been working at home. Interestingly, we found that people were reporting fewer musculoskeletal problems if their organisation had carried out some sort of workplace risk assessment for them, although only 25% of people had. And it's really important, of course, to recognise that musculoskeletal pain has a very high comorbidity with mental health problems. I'll come on to that in a second. We found about 60% of people said they were taking less exercise. About a third of people were worried that their diet had got worse. Over 2/3 of people said they were suffering from sleep problems and fatigue problems. And about 1 in 5 said that they were having experiencing more isolation. Those people with elder care responsibilities, their mental health problems were worse than pretty much everybody else. And focusing more specifically on general health, we were using the WHO-5 wellbeing measure, where we found on that measure that young people working at home have worse mental health. As I've mentioned, those with elder care, those people who have more frequent contact with their direct boss have better mental health. And I'll come on to the implications of that a bit later on. Those people who are underemployed, so those people who aren't actually working as intensively and perhaps feel that they could do more, also are suffering from worse mental health. And we found about 25% of people have said that they've carried on working even though they've not felt well enough to do so. So presenteeism is something that clearly is having an impact. One of the things that managers are not able to do so well under lockdown is to spot the subtle, sometimes non-verbal early warning signs of people suffering from mental distress. And that's something that a lot of managers were becoming more skilled at doing when they're managing people face to face. And one of the real concerns is if we're looking for weak signals in the mental health of the workforce, it may well be that the difficulty managers have in connecting with people or picking up those signs may lead to a problem further down the line. Significant proportion of people are worried about their finances, perhaps understandably. About a quarter were expressing serious concern about money, and about 40% of people were very worried about the health of themselves or family members, and that's perhaps not surprising in a pandemic. And as I mentioned before, communication with bosses does seem to be part of that connectivity. We also have data about how the benefits of keeping in contact with your colleagues as well. We go to the next slide. So we now gathered lots of information here. We're starting to do some statistical analysis of what this all means. And starting from the right-hand side, I suppose what we're really interested in is to see to what extent we can identify what the drivers of mental health are for people working at home. And on the left-hand side, you can see some of the factors that we've now got data on that we think we're going to be looking at, testing this model to see whether or not we can identify whether or not these factors in combination are beginning to explain differences in mental health between different subgroups of the home working population. And we'll hopefully have some data on this over the next week or so. But it is pretty clear that there's a relationship between how people are feeling generally about their work and their organisation. We found interestingly those people who were working at home before the crisis have a mental health scores which are much better, and that suggests to us that there is an adjustment process that people are going through and will go through, which in general will calm things down and allow people to cope better, but provided they're provided with support by their employer. And I'll talk a little bit about that in my closing remarks in a second. So we will be looking at this in a bit more detail. And we're confident that our data will shed some light on not just the determinants of mental well-being in the home working population, but what it means for organisations. Let's go to the next slide to talk about some of those implications. So whatever European country you're in, you have a legal framework that says in some way that employers have a duty of care to the physical and psychological well-being of the workforce. Doing risk assessments is a lot more difficult if people are remote. And we certainly think that that partly explains why there's been a spike in musculoskeletal ill health. But it's really important that employers understand that they need to discharge that duty of care and find ways of providing support and doing things preventatively to support people at work. That means clarifying people's performance expectations, but also doing that flexibly and involving employees in those sorts of decisions. One of the things we did find was that some people are anxious that important decisions about their work were being made without their involvement. So high levels of involvement are really important here, giving people some sense of control and autonomy. Encouraging scheduling, sharing availability, boundary setting within teams. Teams can be a really good way of practically organising work, but also for mutual psychological support. And we think that managers should be doing more to facilitate that. Perhaps focusing less on inputs, i.e. how much time you spend doing your work, and focusing more on how you make sure you get good quality work from people. And that might involve more autonomy and greater flexibility and differences in the way people are working, and perhaps being more tolerant as an organisation about how people work. It's pretty clear, as I said before, that Zoom is no substitute for empathy, being observant, spotting those weak signals of declining mental health, and perhaps supporting managers and colleagues to spot those early warning signs remotely should be an important input. And also, this is about the personal qualities of managers. I mean, many organisations are under a lot of pressure to continue to deliver results, and managers are, in a sense, the squeezed middle. They have pressure from below and from above. What we don't want is for managers to feel they have to continue to be tough on people at a very vulnerable time. So a random act of kindness does not make a manager weak. And it's really important that managers understand the role they play in all this, because they can really make a massive difference, as our data shows, on how people respond psychologically to this crisis. Now, in terms of what might happen next, clearly there are big debates about whether or not working at home might now, the experiment we're in the middle of might remove some of the barriers that some organisations have put up to greater flexible working. It may have shown many of them that actually can work really well, and it might have changed their attitudes. Some of them it won't, but some of them will be thinking now about alternative ways of working once the crisis disappears. And also a debate about things like 4-day week, compressed hours working, and so on may also be something that people are more positive about. We published yesterday some new data we've taken from the European Working Conditions Survey across 27,000 workers across the whole of the EU, which has shown the relationship between precarious work and mental well-being. What it shows very clearly is that the more precarious, the more uncertain and insecure people's work is, perhaps unsurprisingly, the more it threatens their mental well-being. So what I would say is that as employers dip their toe back into the labour market after the crisis, and as that sort of slow recovery happens in economic and labour market strength, we need to recognise that if employers are going to be going for contingent or precarious work as an option to get themselves back into onto the treadmill of work, they need to recognise that the greater precariousness in employment relationships and in employment contracts, the more they're risking mental health. And our data shows that that is not a standard relationship across Europe. There are some countries who do this really well and some who don't. So our message from that is that there are policy choices that countries can make about the extent to which precarious work and mental health are related, and we urge them to take notice of the research data. Final slide. The Institute's survey is carrying on, so it's going to be open for a few more days. So if you or a colleague would like to complete the survey, please follow the link. And if you have any further questions, I'm very happy to answer them either today or via email or Twitter. Thank you.
Thank you very much, Stephen. Of course, this is also very much relevant to me personally and to everybody in our team, and I think everybody that is joining us today. I've seen that we have received quite a few questions, so we were just speaking some of them. Some have already been answered, and some of the most general ones I'll have to pick some of them, and then we will see whether we can provide answers offline to the remaining questions. So one of the questions is from Nigel Henderson, who is CEO of Penumbra in Scotland and one of our senior policy advisors. And it's, as we move to the recovery phase of managing COVID-19, is there the possibility of using the mental health recovery framework CHIME, connectedness, hope, identity, meaning, empowerment, as a way of framing the approach to supporting people and communities to move forward positively? I don't know if any of the speakers knows about this framework and wants maybe to make a comment.
I'm a little bit familiar with CHIME, and hi Nigel, glad you could join us today. I think where there are existing frameworks that are well established, known about, and we know that they're helpful, and CHIME I think is one of those, then I think we should seek to use them. They may require some adaptation, and my knowledge of it is not sufficient enough to be able to give a view about whether that would need to happen or not. But I think that clearly where those frameworks exist, we should use them, particularly if they've been evidenced to work or be of benefit in the past. I think anything that we can do that places some structure around the way in which we can engage with communities is clearly helpful. And I think actually we need to be asking communities to tell us what it is that they need. One of the things that I was told by a very enlightened man called David Jones, who's the Commissioner of Mental Health Services in the city of Philadelphia, is that as professionals, we have to always remember that communities often have the solutions to the problems that they face. What they do not need is us as so-called professionals telling them what those solutions are. We need to encourage them to offer those solutions to us and then work with them to deliver them.
Thank you very much. We have another question, and it's a question actually to all speakers. Are there changes that have come about as a result of the COVID that give our employers, politicians, communities a chance to reorder our priorities? What opportunities do the speakers see coming out from this crisis? And this is from Upgrowth. Thanks.
I can have an initial go at that one, not least because there was another question which was kind of similar about making, the opportunities in the adversity. I think it was asking a similar question, and yeah, as I was alluding to, I think there is enormous opportunity to, let's call it, reframe the debate about mental health in a more positive light, a more empathetic way, and try and dispel some of the myths or the misunderstandings. When people talk about mental health, they think of certain people in mind. Whereas I think after this crisis, I think it's everyone is affected. So I would say there is a huge opportunity. I mean, some countries like the UK have already had a sustained program of changing, public attitudes, and you can see those changes, taking place over 10, 20 years and for the good. But in many other parts of Europe, we still have huge attitudinal barriers and issues. So I see a huge opportunity for a kind of mental health awareness or literacy initiatives. And the other one, I think the big one would be reforming the reorganizing the delivery of psychological support or psychosocial support services through online platforms. So yes, for some people they're not the same, as a face-to-face interaction. But we know that the supply of appropriate psychological support is nothing near to the underlying need in the population, and that need just went up. So I think this is a huge opportunity to actually expedite the increased access to evidence-based psychosocial and psychological support in the population.
Shall I go ahead very quickly, just build on what Dan said, and then I know Stephen was.
Yeah, sorry, I think, yeah, okay, you can speak, and then also Stephen had.
I mean, I think just basically to endorse what Dan said, but I think that actually that there is an opportunity to reorder priorities, and I think the fact that potentially many more people will be affected by potentially some form of mental health problem provides, if you like, the impetus to reorder those priorities and to think about the requirement to invest adequately in the right range of different approaches. And I think, to come back to my original point around population mental health and well-being, to really encourage politicians to see that every pound or euro or dollar that's invested in that sort of approach will pay off, and for them to think about the fact that the delivery of improvement and improved outcomes is not the work of a moment. It will take some time, but actually that will pay off. So to try and think a little bit longer term in terms of those priorities, rather than simply what can we do in the next 6 months, 12 months, or whatever the electoral cycle might be, but to say actually you can create a very strong legacy amongst communities if you invest in that sort of approach on a long-term basis. And I would hope that politicians and employers now are beginning to realise, through some of that improved mental health literacy, that there is a huge benefit for them, both in terms of productivity, Stephen mentioned it, reductions in presenteeism and absenteeism, and just a general improvement in people's working conditions and mental health more broadly will be brought about through such a reordering. So I think we have an opportunity to make that case.
Just to add something briefly from a sort of employer perspective, I think we've known for a long time that good quality work, high levels of job quality have been strongly linked to better well-being, psychological well-being and productivity and performance. And I think this has intensified interest in that. And I think that more employers are getting, through this live experiment, evidence that giving people autonomy and challenge and control and variety in their jobs and trusting them to do their jobs well can be a really positive boost to mental well-being at work. And it's going to be harder for some of those who are resistant to that argument to go back.
Thank you very much. I think we only have time for, unfortunately, for one more question, but we will try to save all questions and see if we can provide information on this in the upcoming days. So I see here that there is a question from Marionneke de Wetten. Economic and public mental health are two sides of the same coin, and indeed the growing awareness in these times might be a great opportunity to give mental health the attention it deserves, to include mental health in our policies and to encourage collaboration between sectors. What can we do to make this happen, and how could international collaboration help to achieve this? Anyone wishes to say a few words?
I was hesitating because I'm conscious I jumped in earlier, but I'm happy to just respond to Marionneke, and hello and good to see you, Marionneke. He's a good friend of WMHL, as Claudia will know. I mean, I think that in terms of collaboration, I mean, there's no doubt that through collaborating we can share innovation and good ideas. And I think that in this period of crisis, we have to understand that what might have worked before might not work in the future. And that may lead not only to adaptation, but to innovation. And innovation can only really be stimulated by people working together. That kind of disruptive thinking that we require is really important. And what I'd like to see happen is that organizations and countries do that as effectively as possible together. We bring, you know, a range of different and diverse perspectives when we work together, and we often get much more improvement as a result of that. And I think the fact that colleagues in Europe in particular have demonstrated an ability to share examples of their own practice through our work in WMHL with countries outside of Europe and countries indeed that aren't members of our organisation. And the Netherlands has been particularly good at that I think in particular in relation to FACT as an example of a type of service. So I think we can collaborate effectively, we can have an impact on policy, but we can have an impact on service, but we can also have a very important impact on that broader public mental health debate, as well as a broader public health debate, actually, because physical and mental health, as we know, are intrinsically linked. And I also think that we have to try and frame that discussion collectively in terms of thinking about trying to close the gap between what we mean by the economic argument around this and the health argument around it. And actually health and economics are not separate sides of the street, they're right down the middle together. So I think anything that organisations such as YKZ can be doing to try to stimulate that kind of thinking, that collaboration, not only in their own country, but more broadly, I think we can create more rapid progress. And one of the aims of IMHL, for example, is through that collaboration to speed up innovation and innovation's implementation. So I'm all for that.
Thanks. Some brief comments from Dan and Stephen, if you want.
Okay, yes, we're about to finish, but just to add, I mean, Steve is representing IIMHL, I'm representing WHO, you're representing Mental Health Europe. They all are about international collaboration. So I think, you know, that tells its own story. And just to say that, I mean, certainly from WHO Europe side, we have a new regional director, and mental health is right, you know, in his plans. And so, you know, at the sort of international level, of course, you know, we want therefore to strengthen the collaboration with multiple different stakeholders and partners, just as you do in country national level, and then right down to the community level, like what Steve was describing with these local resilience forums, which is a perfect way to air those multi-sectoral issues. And yeah, I just repeat the point that, I mean, you know, it's easy to talk about mental health and all policies, but we know it's fantastically difficult to do in reality. But that reality just changed, and so I think that we have a window of opportunity to restate the case, and we need to back it up though with evidence and information, so that people are let's say sufficiently persuaded and convinced of the benefits of it. And then also, of course, that's where leadership, I think, comes in, and why we are very keen to explore our collaboration with IIMHL more in building up that leadership, not just in the policy sense, but in the civil society organizations, service providers, and other relevant levels in the mental health systems. Over and out from my side.
Thank you very much. So I'm afraid we've run out of time. I saw that there were also quite a few questions on related to employment. But what we will do, we're trying to save these questions, and we will try to provide some answers offline, as I mentioned before. So this recording will be available online, and you will receive a link to it. And the last thing, as I announced at the beginning, is that we actually had a rather exciting announcements to make, and this is that Mental Health Europe is going to launch the first European Mental Health Week, which we start this coming Monday on the 4th of May, and it will go all the way to the 10th of May. We would like everybody to get involved, to share stories, to share their tips, to raise awareness of mental health, and to use our hashtag Together We Can. So as Dan said today, and that's why I made that remark, togetherness is a protective factor during the COVID-19 crisis. And so now is the time for everyone to come together, to support each other, focus on mental health, but also to work each other as much as we can across sectors, to work with each other as much as we can internationally. It's really, now is the time. So mark your calendars and stay tuned, and be sure that you check your emails and AMH's website and social media on Monday for more details. So thanks very much. I would like to thank all of our speakers, all of you that attended the webinar, and of course, my team that supported me through the whole hour and a few minutes right now. So we'll be in touch soon. Bye-bye.